Her name, for our purposes, is Elena. 31 years old, laparotomy for a bowel obstruction. Induction was unremarkable. Vitals stable throughout. No tachycardia, no hypertension, no movement. 2 days later, on the ward, she told the resident she remembered the drapes going up. She remembered the cautery. She remembered a voice saying the suction was clogged. She had been paralyzed and unable to signal. Her heart rate had not changed. I have been a physician for 19 years. This is one of the cases I cannot explain. Anesthesia awareness is the explicit recall of sensory events during a procedure intended to be carried out under general anesthesia. The patient is immobile because a neuromuscular blocking agent has paralyzed them. The patient is, by every external measure, unconscious. And yet, afterward, they remember. They remember voices. They remember pressure. Sometimes they remember pain. The incidence, across the general surgical population, is estimated at 1 to 2 cases per 1,000 general anesthetics, roughly 0.1 to 0.2%. In 2004, Peter Sebel and colleagues published a multicenter prospective study in Anesthesia and Analgesia, surveying 19,575 patients across 7 academic centers in the United States. They identified 25 cases of definite awareness, an incidence of 0.13%. They also found that patients with higher ASA physical status, meaning sicker patients with less physiologic reserve, were at elevated risk. That number, 0.13%, sounds small, but scale it. In the United States alone, roughly 21 million general anesthetics are administered each year. At that rate, the arithmetic produces somewhere between 20,000 and 40,000 episodes of intraoperative awareness annually, and those are the cases patients report. The true figure is almost certainly higher because direct post-operative questioning about awareness is not uniformly performed, and because recall sometimes does not emerge for days or weeks. In specific surgical populations, the rate climbs sharply. Cardiac surgery, up to 1.5%. Emergency cesarean section, between 0.4 and 4%. Major trauma surgery, where the anesthesiologist must run the lightest possible anesthetic to preserve collapsing blood pressure, has reported rates as high as 11 to 43% in some series. These are the patients who cannot tolerate a deeper plane. The drug that would guarantee unconsciousness would also kill them. The phenomenon itself is not new. Accounts of intraoperative recall predate modern monitoring by more than a century. The anesthesia literature of the 1950s and 1960s, when curare and light inhalational agents were often paired, contains a significant body of case reports describing patients who recalled conversations and sensations from the operating room, many of whom were dismissed at the time as confabulating or dreaming. Ghoneim and Bloch, writing in Anesthesiology in 1997, formalized the distinction between explicit and implicit memory during anesthesia, and laid the groundwork for everything that followed. What is new is not the pattern. What is new is that we can now sometimes measure it, and still fail to prevent it. The mainstream position, which I hold in most cases, is that anesthesia awareness is a pharmacologic failure, not a mystery of consciousness. The patient received insufficient anesthetic relative to their physiology, and consciousness, which was never abolished in the first place, persisted at a level sufficient for memory encoding. Understood this way, awareness is a dosing problem. The mechanism is reasonably well characterized. Volatile anesthetics, such as sevoflurane and isoflurane, and intravenous agents such as propofol, act primarily by potentiating GABA-A receptors, the principal inhibitory receptors of the central nervous system. They hyperpolarize cortical and thalamic neurons. Functional imaging and intracranial EEG studies have shown that surgical anesthesia is associated with a breakdown of long-range frontoparietal connectivity, a disruption of thalamocortical feedback, and a collapse of the integrated information that, in most contemporary theories, corresponds to conscious experience. George Masher's group at the University of Michigan has published extensively on this signature of disconnection. When the dose is inadequate, that disconnection does not fully occur. Skeptics go further. Michael Shermer has argued that much of what patients report as intraoperative awareness is more plausibly explained by post-operative confabulation, by anesthetic-induced dreaming, or by implicit auditory processing, reconstructed as explicit memory during the confused emergence period. Anil Seth, in his work on the predictive brain, has emphasized how readily the nervous system constructs coherent narratives from fragmentary signals. Dreams during anesthesia are common, vivid, and easily mistaken for recall. The distinction matters because it determines whether we are treating a pharmacologic event or a psychological one. Instrumentation has been deployed against the problem. The bispectral index, or BIS, is a processed EEG monitor that renders a dimensionless number from 0 to 100 meant to index anesthetic depth. In 2004, Paul Miles and colleagues published the Be Aware trial in The Lancet, a randomized controlled trial of 2,163 high-risk patients that reported an 82% reduction in awareness with BIS-guided anesthesia compared to routine care, 2 cases versus 11. That result did not replicate cleanly. In 2011, Michael Avedon and colleagues at Washington University published the BAG Recall trial in the New England Journal of Medicine. 6,041 high-risk patients randomized between BIS guidance and end-tidal anesthetic concentration guidance. BIS was not superior. There were 7 definite awareness cases in the BIS group and 2 in the ETAC group. The monitor designed to close the gap had not closed it. The consensus that emerged is cautious. BIS is a useful adjunct, not a guarantor of unconsciousness, and the underlying EEG signature of awareness remains incompletely understood. The consensus holds, mostly. It begins to fracture at the edges in specific cases that are difficult to explain with dosing errors alone. Consider a case published in 2024 by Bowdle and Hasnain, a 31-year-old woman undergoing elective abdominal surgery. Induction was standard. She described falling asleep as patients do, within seconds of the propofol bolus. Then, she reported on the first post-operative day, she woke. She felt, in her words, pulling and cutting at her abdomen. She tried to move. She could not. She tried to breathe against the ventilator. She could not. She heard a member of the surgical team call out an instrument count. She heard an overhead page for another operating room. Her monitored vitals, throughout, remained within normal limits. Her BIS, when it was recorded, stayed in the recommended range. Consider a second case, from a medical liability review. A 34-year-old man, hernia repair, in whom a propofol infusion line was found after the fact to have been disconnected from the IV for approximately 35 minutes. The pharmacologic explanation, in his case, is straightforward. He was underdosed because he was not receiving the drug. But what makes the case instructive is what he reported afterward. A coherent, chronological recall of the procedure, intact working memory, intact auditory processing, intact semantic comprehension of the surgical team's conversation, intact emotional appraisal, intact formation of long-term episodic memory. Every cognitive faculty that we associate with wakeful consciousness was, during those 35 minutes, online. And no external signal indicated it. This is where the question shifts. The question is not whether sub-anesthetic doses can permit consciousness. We know they can. The question is why, in cases like Elena's, with adequate drug delivery, stable vitals, and monitor values within range, Consciousness is nonetheless present and encoding memory. The question is not what the monitors are measuring. The question is what the monitors are missing. Elena, the patient from the cold open, is a composite drawn from cases like these. Her laparotomy was covered by a standard propofol and remifentanil TIVA. Her BIS values logged between 40 and 50 throughout, squarely within the range that is supposed to correspond to adequate general anesthesia. Her end-tidal CO2, heart rate, and mean arterial pressure were unremarkable. No drug pump alarmed, no line was disconnected. On every metric available to the anesthesia team, she was unconscious. On her own account afterward, she was not. For her account to be true, several faculties had to have been concurrently intact. Auditory perception, sufficient to parse speech. Language comprehension, sufficient to understand what was said. Working memory, sufficient to hold the sequence of events. Episodic memory consolidation, sufficient to retain it for days. Emotional processing, sufficient to encode the fear she later described. And metacognition, sufficient to recognize in the moment that she was awake and should not be. All of this while the monitors said otherwise. The psychological cost is not hypothetical. Up to 70% of patients with confirmed awareness develop significant psychological sequelae. Between 10 and 25% meet criteria for PTSD. Njue and Kinyungu in 2021 described a 34-year-old woman intubated at the bedside for tonsillar hemorrhage who developed full PTSD, defined by the persistence of the paralyzed helplessness she had experienced. The trauma in these cases is not the pain. The trauma is the unbridgeable distance between what the body signaled and what the mind knew. What would it take to close this gap? Not to explain it away, but to measure it. Processed EEG in its current form is a reduction. BIS collapses a complex high-dimensional electrical signal into a single number, using a proprietary algorithm trained on populations. It is an index, not a readout of consciousness. Several active research programs are trying to build something better. At the University of Michigan, the Center for Consciousness Science, under George Masur, is studying multi-channel EEG signatures of anesthetic state transitions, examining measures of cortical complexity and directed connectivity that correlate more tightly with subjective report than BIS does. At Washington University in St. Louis, Michael Avidan's group, following BAG Recall, continues to investigate which combinations of monitoring and pharmacologic strategy actually change patient outcomes. At Imperial College London, the Next Generation Neural Interfaces Lab is developing multimodal systems that combine EEG with hemodynamic and autonomic signals in an attempt to produce a more faithful index of the conscious state. None of these is, yet, a direct measure of consciousness. The instruments that would do that do not exist. They would need to read in real time, not the aggregate electrical activity of the scalp, but the integration of information across thalamocortical networks. They would need to distinguish a brain that is processing a surgeon's voice from a brain that is merely registering sound. They would need to separate dreaming from awareness, implicit memory from explicit, unconscious startle from conscious fear. We do not have those instruments. We may not have them for a generation. This is what I mean when I say that consciousness is the fifth vital. We monitor 4: heart rate, blood pressure, respiration, temperature. A fifth signal is present in every patient under our care. It shapes every outcome that matters, and we measure it only by inference, only by proxy, only retrospectively, and by asking. In the operating room, we assume its absence. We do not confirm it. Every surgical day, in every hospital, we proceed on that assumption across millions of patients. And most of the time, we are right. Sometimes, as in Elena's case, we are not, and we do not know until afterward if the patient chooses to tell us. Current medicine cannot reliably detect consciousness in a paralyzed patient. It cannot reliably distinguish, in the moment, a dreaming brain from an aware one. It cannot yet identify, before surgery, which patients carry a genetic or neurophysiologic susceptibility to awareness at standard doses, though that work is beginning. And it cannot undo the encoding of a traumatic memory once the operation is over. These are not failures of effort. They are the edges of what the tools permit. Elena was discharged on post-operative day 5. Her wound healed without complication. On paper, her surgery was a success. The bowel obstruction had been relieved, the resection margins were clean, her labs normalized. The 2 details I did not tell you at the beginning are these. Her recall did not emerge until the 2nd post-operative day. On the 1st, she remembered nothing, and had she been asked at that moment, she would have said the anesthetic was fine. And on the evening, she told the resident what she remembered. She also said that the sound she could not stop hearing, the sound that followed her into sleep and woke her from it, was not the cautery and not the voices. It was the rhythmic hiss of the ventilator cycling, breathing for her, while she tried and failed to breathe for herself. She was referred to psychiatry. She was offered trauma-focused therapy. She declined further elective surgery for as long as she could defer it. Her anesthetic record, reviewed afterward by 2 independent attendings, was within standard of care. No one did anything wrong. The monitors did what monitors do. The drugs were delivered at appropriate doses. And, somewhere between the numbers on the screen and the person on the table, something happened that the numbers did not describe. I do not know what consciousness is. I do not know why it persists, sometimes, in brains we have pharmacologically silenced. I know only that it does, that we cannot yet see it when it does, and that the people it happens to remember.